Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be covering burns. Now, I'm sure you guys have noticed by now, depending on what I'm teaching, I use a different book. And the reason for that is I noticed that depending on the book that I'm using, some books, they organize the information in the way that I like. So I may be teaching, burns out of this book, but I may be teaching psych out of another book. I may be teaching integumentary out of another book. It just all depends. But today on this video, I'm going to be covering burns, and I'm going to be teaching out of this medical surgical textbook. So you see what it looks like. Let me show you the author, because I know I get this a lot in the comments where you want to know who the author is. You want the book to get it off Amazon or whatever. So for burns, if you'd like to follow along and you'd like to get this book, this is the book that I'm teaching from for burns. Okay, and all you have to do is press pause if you didn't catch that. So let's get started. Here we go. I might need to elevate this. There we go. All right, so I want you to see this. I wrote this down because I didn't want to forget to talk to you guys about this. When it comes to burns, the first four things that needs to be going on in the back of your mind immediately when you hear burns are these four things. Shock. Professor D, shock. When a person's, extremely burned, they're all puffy with fluid. How shock? I'll explain that to you. But yes, shock, because what happens is all of the fluid that should have been in the vascular space, that protein that holds it and keeps it in that vascular space, is now gone. And so all of that fluid goes out into the tissues. So even though this person is swollen, they look like they're full of fluid, there's no full fluid in the vascular space. And so what happens is those organs start to shut down. So you need to think of shock, right? Electrolyte imbalance. I just told you that all of the fluids, that includes the blood, that includes the minerals, that includes the electrolytes that were in the vascular space, what happens? It causes a shift. So this patient's going to have severe electrolyte imbalance. We're going to talk about that. Infection. Think about it. Person has a burn. Do you think their skin integrity is going to be intact? No. So that's going to be a perfect opportunity for pathogens to get inside of the body, because your first layer of protection is your skin, which is now compromised because of the burn. And pain. I always say this to you guys, pain never killed anyone. Whenever you're asked about a priority, pain is never a priority, except in certain situations, including burns. Right? Remember burns, MI, sickle cell, cancer treatment, those type of patients, pain is a priority because pain is so bad. Oh, stones as well, like kidney stones, gallbladder stones. In those types of situations, the pain is so intense, it puts that patient's physiological integrity at risk. Right? So these four need to be a priority in your mind whenever you hear burns. So let's get started. Make this a little bit bigger for you. All right, pathophysiology of burns. Look at what it says. It affects fluid and electrolyte balance and leads to protein losses. Let's stop right there. Remember, let me tell you something. Part of your blood, the albumin, what is that? Protein. That is what's keeping the fluid in that vascular space. And look what it just said. This is the first thing it said. It leads to fluid loss. So not only fluid loss, protein loss, I should say. So along with that protein loss, what protein is what was keeping all of that fluid in the vascular space. Once that protein's gone, guess what the fluid says? I'm out of here, and it leaves that vascular space. It leads to protein loss. Sepsis. What is sepsis? A severe form of what? Infection. And changes in metabolic, endocrine, respiratory, cardiac, hematologic, and immune functioning. Burns affect basically every portion of the patient's body. Look at this. A lack of or delay in wound healing is a key factor, is an essential factor for all systemic problems and major cause of disability and death among patients who are burned. Why? Remember, Number one, your skin is your first line of defense against infection. And number two, if we don't get that protein back in the vascular space where it belongs, which means we don't get that fluid back in the vascular space where it belongs, what do you think is going to happen to your organs? They're going to shut down. Okay, so it's very important for tissue healing and getting the protein back where it belongs. All burn injuries are painful. I want you to notice something. It didn't say some, it said all. What did I teach you guys when you're studying and you see those absolutes, such as all, always, never, only? You better highlight it. You better put a star next to it. That means it's very important. All burn injuries are painful. Skin exposed to sunlight activates vitamin D. Remember, the sun rays, that's a source of vitamin D. Skin exposed to sunlight activates vitamin D. Partial thickness burns, look at this, reduces the activation of vitamin D. And it makes sense if it's the skin that's getting those rays for the patient to get the vitamin D, but now that skin is compromised. Of course, it makes sense that that activation of vitamin D is going to be compromised as well. And you guys know what vitamin D is important for. You can have as much calcium as you want in the world. If you don't have vitamin D to activate that calcium, to help you absorb that calcium, what's the point? Let's take a look over here, next page. You guys absolutely must know the difference. Let me go over this one first. You have to know the difference of the depths of burns, okay? And that's why I said no, and I put 3 exclamation marks there. Trust me, as a nursing instructor, I've been doing this for a long time. I guarantee you, if you're in med-surg right now and you're doing burns, you're going to get at least 1 question on this. And I'm being very conservative when I say at least, because you're going to get several questions. You need to know the difference. So let's talk about it. Superficial burns. That means it's very, very superficial on the very top. Look, the epidermis, the very top of the skin. Superficial burns damage only, oh, there goes another absolute, only the top layer of the skin. That's your epidermis. The epidermis healing occurs in 3 to 6 days. And the reason the healing occurs so quickly is because only the top layer was affected. Superficial partial thickness burns are those in which the entire epidermis, look at this, and portions of the dermis layer of the skin are destroyed. So the very top plus some of this dermis is destroyed. Uncomplicated healing will occur in about 10 to 21 days. Now you got full thickness. This goes all the way through the entire dermis. So that means it cuts through the epidermis, all the way through the entire dermis, and sometimes into the subcutaneous fat. We've gone from that layer of the skin into the subcutaneous fat. If it gets down here, guess what? That skin cannot heal on its own. It's going to need some assistance. Take a look at this table, some things I want to cover with you that you absolutely need to know. The difference between your minor burns versus your moderate burns versus your major burns. And if you don't have this book, just press pause, guys. Press pause, take a picture of it, do index cards, whatever, but make sure you know this information. So with the minor burns, partial thickness burn loss is going to be less than 10% of that total body surface area, okay? No burns to the eyes, ears, face, hands, feet, perineum. No electrical burns, because let me tell you something, when we're dealing with electrical burns, that is not a minor burn. Because if we're dealing electrical burns, what's one of the patient's biggest risks? Their heart, okay? No inhalation burn. Inhalation burn, that is not a minor burn, because if that patient has inhalation burn, there's a big chance that, you know, they breathe in that noxious fumes and their throat might close up on them, or that patient might have, what's the word I'm looking for? It's not coming to me. Pulmonary. That patient may have pulmonary edema, right? So that's not minor. And you guys can look at the rest. Here are some comments important for you to know. So if it's a minor burn, we're not dealing with any inhalation injury. We're not dealing with electrical type of burns. The patient didn't have any burns to, you know, their eyes, their ears. knows where there's a chance that they breathe in the smoke, it's a minor burn. They're going to get emergency care at the scene. And then a special expertise or hospital designated burn center is usually not necessary. We don't have to transfer them to a special burn center because the burn was minor. Take a look at moderate burn. Moderate burn, guys, you I can't speak. Take a look at this list, just pause it, make sure you know what this list is for moderate burns, but here's what's important to know about the moderate burn. They're going to get emergency treatment at the scene, and they need to be transferred either to a special expertise hospital or to a designated burn center. Major burns. And I put a star next to the ones that tend to show up the most on exams. You need to know that these are major burns. Any burn involving the eyes, ears, nose, the face, feet, perineum, that's considered a major burn. Electrical injury, because we know that that can cause a patient to have cardiac dysrhythmias. That's a big one. Inhalation injuries, we're concerned about the lungs. Patient older than 60 years old, patient having cardiac, pulmonary, or other chronic metabolic disorders. Here are the comments that you need to know. Patients who meet any one of them, just any one of this criteria for a major burn should receive emergency care at the nearest emergency department and be transferred to a designated burn center as soon as possible. You notice how the other one said, care at the scene. This one says that they need to go to an ER as soon as possible. And then after that, transfer to a specialty hospital that cares for burn patients. So we went over our superficial, partial, deep partial, and full thickness burns. Let's see what else the book has to say. And this is something else that I've talked to you guys about. Whenever you're reading, you're studying, you're seeing that the book's talking about something in the text, and then you see it again in a table, a diagram, a box, an illustration. That means it's important to know there's a reason why they're presenting that same information to you in a different way. So let's talk about the superficial thickness wounds, okay? Superficial thickness wounds. These have the least damage because the epidermis is the only part of the skin that's injured. And we know that because look, didn't we just see up here, superficial burns, only the top of the skin layer? Why do you think the author took the time to put it here in a figure, and that same thing they put in the figure, they now gave it to you in a text? Because they know you're going to get a test question on the different types of burns and you're expected to know it. Desquamation, this is peeling of dead skin. It occurs 2 to 3 days after the burn. And remember, the healing is the quickest because only the top layer is affected. The deeper that burn goes, the more complicated that burn is going to be and the longer it's going to take to heal. Partial thickness wounds. Partial thickness wound involves tissue integrity loss of the entire epidermis, so the entire top layer, and different depths of the dermis, which I already showed you guys. So let's take a look. Superficial partial thickness wound. This is the upper third of the dermis, leaving a good blood supply. These wounds are pink and moist, and they blanch when pressure is applied. So take a look at my, this isn't really good. I got nails on. But anyway, what happens is, guys, the skin is normally, if we're speaking about a Caucasian person more, you can see, but if you're looking at the palm, it's nice and pink, right? Then when you apply pressure, it blanches, but then as the circulation returns, it's supposed to be nice and pink again. That pink color is from the blood return. Deep partial thickness wounds. This extends deeper into the skin, dermis, fewer healthy cells remain. Blisters usually do not form because the dead tissue layer is thick. It sticks to the underlying dermis and does not readily lift off of the surface. So it makes it even harder for it to heal as well. Look at this, blood flow to these areas is reduced. And guess how healing occurs? From blood flow, because that blood is what's carrying the oxygen, the vitamins, the nutrients, the minerals that the tissue needs to regenerate. All right, moving on, full thickness wounds. A full thickness wound occurs with destruction of the entire epidermis and dermis, leaving no skin cells to repopulate. This wound does not regrow and areas not closed by wound contraction. So when it comes to a full thickness wound, guess what? For this patient to heal, guess what? They're going to need some help. The skin's not going to do it on its own. Look at this. The full thickness burn has a hard, dry, leathery eschar that forms from coagulated particles of destroyed skin. So that eschar, guys, it's dead. Make sure you watch the video I did. I have about 3 or 4 videos in my integumentary playlist. And out of those 3 or 4, I know at least 2 of them I have on burns. Make sure you watch it so you can understand how to answer these questions on burns. The eschar is dead tissue. It must slough off or be removed from the skin before healing can occur. Because let me tell you something, if it's not removed, more skin is going to die. There's no way that that tissue can heal with that dead skin lying on top of it. Escharotomies, these are incisions through the eschar, remember that dead tissue. Or fasciotomies, this is incision through eschar and fascia. Let's go to deep thickness wounds. Deep thickness wounds, this is a wound that extend beyond the skin and damage to muscle, bones, tendons occur. All full thickness burns need early excision and grafting. Grafting decreases pain and length of stay and hastens recovery, but it's very painful. We're going to talk about that. Is very painful. So this patient is going to have to be medicated, and they're going to be medicated with narcotics. We're not giving them Motrin or acetaminophen, okay? Amputation may be needed when an extremity is involved. So let's go over vascular changes. Vascular changes resulting from burn injuries. Fluid shift. Fluid shift occurs after initial vasoconstriction as a result of blood vessels near the burn dilating and leaking fluids into the interstitial space. Look at this. This fluid shift, also known as third spacing or capillary leak syndrome, is a continuous leak of plasma from the vascular space into the interstitial space. And that fluid's following that plasma. Okay, and the thing is, remember that plasma is what was keeping the fluid in the vascular space to begin with. Let's go to the next slide. Edema develops as plasma and electrolytes that's in the fluids escape into the interstitial space. So plasma, which is part of the blood, which has always been in the vessel, that's what's been keeping the fluid and all of the electrolytes in the vessels where they belong. Because remember, all of the fluid and the blood that's in the vessels, that's what's perfusing the organs. But now that the plasma has left the vessels, the fluid has left the vessels, the electrolytes have left the vessels, your heart, your kidneys, your liver, your spleen, all your vital organs, how are they going to be perfused? Okay? Look at what this says. It says the proteins now in the interstitial space, where should it have been, guys? It should have been in the vascular space, but now in the interstitial space, increases the movement of fluids out from the vascular space. So the culprit is the protein which has left that vascular space. Okay, remember the part of the blood is protein, and that part has left, that plasma is left, and that fluid is not trapped in the vascular space anymore. Look at what this says. Excuse me. Oh, by the way, guys, if you've been following me for any amount of time, you know how it goes. Summertime. Today's the first day of summer. You guys know I'm Mama Bear. So all of the cousins for the summer, they're at my house. So if you hear running, screaming, all of that, just know it's the first day of summer. So I have a whole summer of kids. So when I'm doing my videos for the next 7-8 weeks, if you hear something crazy, just ignore it. You know it's one of the kids. All right, guys, so look at what it says. It says, these imbalances often include hypovolemia. So the fluid volume we used to have in our vascular space, we don't have it anymore. The fluid volume is down. That's why it's hypovolemia. Metabolic acidosis, hyperkalemia, too much potassium. In why do I have a, oh no, I was underlying underlying something else. Too much potassium where? In the blood. Remember, your potassium is supposed to be 3.5 to 5, very narrow therapeutic range. This person has hyperkalemia, so we may see that potassium go higher than 5. Hyponatremia, you guys know sodium, potassium go the opposite way. So as we see that potassium going up, we see the sodium going down. Sodium's supposed to be 135 to 145. That's the normal therapeutic range. So for this type of patient, we'll see that sodium less than 135. Now, let's figure out what's going on here. Why are we seeing this electrolyte imbalance? You guys have to understand this. Don't try to memorize it, because as an instructor, from one concept, I can create 50 test questions. But if you understand the concept, no matter how your instructor makes a test question, you'll be able to answer it. So don't try to memorize, try to understand. Let's look at what's happening here, guys. Hyperkalemia. Remember, potassium is supposed to be 3.5 to 5. Hyperkalemia, the potassium is higher than 5. There's too much potassium in the blood. Why? Look at what it's saying. Hyperkalemia occurs as a result of direct cell injury, and it releases large amounts of cellular potassium. So as that skin is burned, the injured cells, look at what's releasing. Potassium. It's releasing potassium from the cells. Sodium, remember, patient's going to have hyponatremia, so the sodium is going to be down. Normal sodium is 135 to 145. This patient's going to have lower than 135 sodium. Look at what it says. Sodium is retained by the body as a result of the endocrine response of stress. But look, let's keep going, guys, because I know what you're saying. Well, Professor D, it says the sodium is retained by the body. Wouldn't the sodium be up? Look at what it says. This sodium, however, quickly passes into the interstitial spaces of the burned area with the fluid shift. Guys, whenever we're talking about fluid electrolytes, are we talking about those fluid electrolytes in the tissues in the interstitial space, or are we talking about fluid electrolytes in the vessel? We're talking about fluid electrolytes in the vessel, because that's where it matters. It's what's in the vessels that's going to the organs to perfuse the organs, not in the tissues. So yes, the body's holding on to it, but it's not in the vessels. Look where it's located. What was I? Right here in the interstitial spaces. Thus, despite the increased amount of sodium in the body, most of the sodium is trapped where? In the interstitial space, and sodium deficit occurs where? In the blood. The blood is where it matters. That's why it's called hyponatremia. Emia. What is emia in the blood? Hyperkalemia. Emia. What is emia in the blood? We care about these things that are in the blood, in the vessels, okay? Not in the interstitial spaces. So you guys have to, it makes sense that you guys understand why the potassium is going to be high, because as the skin burns, those cells are releasing potassium. In the vessels, the potassium is going to be high, but in the vessels, the sodium is going to be what? Low. Let's keep going. Hemoconcentration, elevated blood osmolarity, hematocrit and hemoglobin develops from vascular dehydration. So because all of the fluid has left that vascular space, what's left is very concentrated. And that's what we call that hemoconcentration, right? And so that's why we'll see an elevation of hematocrit and hemoglobin. I'm going to tie this in for you. Elevated H&H is a symptom of what? Dehydration. Isn't this what's happening in burns? Because when we're talking about fluid, we're talking about fluid where? In the vessels. And when it comes to burns, all of the fluid leaves the vessels. It goes to the interstitial spaces. So the patient has these signs and symptoms of dehydration. Elevated H&H is a sign and symptom of dehydration. And the reason that this is happening is because of the hemoconcentration. When you see an elevated H&H, you need to be thinking dehydration. Okay, let's keep going. Fluid remobilization starts about 24 hours after injury when capillary leak stops. What is fluid remobilization? When all of the fluid that went to the intravascular space, when it comes back to the vascular, I can't speak. When all of the fluid that went into the interstitial space came back into the vascular space. That's what the remobilization is. It came back to where it was supposed to. It happens 24 hours after injury when the capillary leak stops, because the capillary leak is when all of the fluid leaves the vascular space and goes out into the interstitial tissue. So when that stops, the plasma comes back, and so does the fluid and nutrients. Okay. So when this happens, blood volume increases, because all of the fluid that was in the interstitial space now comes back to the vascular space. Now comes back to the vascular space. If I had time, guys, I would have speech therapy. I just don't have the time. I'm sorry, you're gonna have to deal with this. Look at this. Body weight returns to normal. What does this tell us? Body weight returns to normal. As a student, and I saw this, I would say, oh, so this means something was going on with their body weight, right? So this already lets me know as a student that when a patient has burns, I'm going to have to be keeping an eye on their weight, because as the weight goes back to normal, I'll know that that's one of the things that let me know this patient's getting better. Hypokalemia, that's low blood potassium, results from potassium moving back into cells and also being excreted in urine. Let's stop right there, because, oh my goodness, this just said a mouthful to me. Let's stop. So patient gets burned. Because of the burn, the cells release all of this potassium in the vascular space. Patient has hyperkalemia, right? Wonderful. Now the capillary leak has stopped. Fluid remobilization has begun. So fluid comes back to the vascular space. So number one, the potassium is being diluted from all the fluid coming back. And number two, the kidneys start to function again. So the patient's urinating and the patient's losing potassium through the kidneys. So that places that patient at risk for hypokalemia. This lets me know that when the patient has a burn, those kidneys shut down. How do I know? Look at what it says. Hypokalemia, low blood potassium, results from potassium moving back into the cells and also being excreted in the urine. Why was it excreted in the urine before? Because the kidneys were not letting urine go. It was not releasing urine. Let me tell you something. Whenever something severe or tragic happens to the body, your body's meant to survive no matter what. One of the first things to shut down is the kidneys, because the kidney goes, whoa, I don't know what's going on, but whatever vitamins, minerals, nutrients, oxygen that we have, we're going to hold on to. I'm shutting down. I'm not letting anything through until we figure out what's going on. So when this person has a severe burn, the kidneys shut down. That patient's not releasing any urine. So not only is the potassium going up because the cells are releasing the potassium in the vessels, the person's not urinating. So the potassium that normally would have left in the urine, the patient's holding on to. But as things start to get better after that 24 hours, when the capillary leak stops and remobilization occurs, the person will start to urinate again, okay? Anemia often develops as a result of hemodilution. Remember, at first, that H&H was up because of the dehydration. All of the fluid left that vascular space. But now, because fluid remobilization, all of that fluid is now coming back. It's diluting those the hemoglobin. You start to see the H&H start to go back down, and we start to see anemia. Metabolic acidosis is possible because of the loss of bicarb in the urine and increased rate of metabolism. Those two things that are happening. The kidneys now allowing the urine to be released. So bicarbs being lost in the urine, right? At large amounts. So with the loss of bicarb, that's going to put the patient in a more acidic state, number one. And then number two, increased rate of metabolism. Why do you think the rate of metabolism has increased? The body's trying to heal. Moving on. Cardiac changes resulting from burn injuries. Heart rate increases. Cardiac output decreases because initial fluid shifts and hypovolemia that occur after burn injury. And it makes sense, guys. That cardiac rate is going to increase because the heart is trying to compensate. It's trying to push out the oxygen that's carried in those RBCs. Remember, the hemoglobin that's in the RBC is what carries the oxygen. So it makes sense that the heart does that, it's trying to compensate. Cardiac output improves with fluid resuscitation. Pulmonary changes. What happens to the lungs after burn injury? Respiratory problems are caused by superheated air, steam, toxic fumes, or smoke. Breathing that stuff in, what do you think is going to cause? What do you think it's going to cause? Inflammation, swelling. Such problems are a major cause of death in patients with burns and are most likely to occur when the burn takes place indoors. Because if it's indoors, you have no choice. If you're very close to that area, you're going to breathe it in. It's not like the fire was outside where you had a chance to get away. You could breathe fresh air. But if you're in the same room with that fire, the chances are very high, very likely that you're going to breathe in that smoke, those toxic agents that can cause inflammation of the airway, that can cause swelling, right? And that is a major cause of death when it comes to burns. GI changes. Oh, there's one more thing. Hold on, guys. Down here, what does it say down here? Progressive pulmonary failure develops, leading to acute pulmonary insufficiency and infection. Let's break this down. Progressive. That means as time goes on, it only gets worse. So progressive, as time goes on, it only gets worse. Pulmonary failure develops. Do we care about anything else if the patient can't breathe? No, right? So as time goes on, it gets worse. The lungs fail, and that leads to acute pulmonary insufficiency and infection. GI changes resulting from burn injury. The fluid shifts and a decrease in cardiac output that occur after injury decreases blood flow to the GI tract. Let me explain that to you. So when the burn happens, remember, the body's trying to survive. The kidneys have shut down, patient's not urinating, the heart rate increases because it's freaking out. Hey, what's going on? Let me try to get oxygen, vitamin, nutrients to the rest of the body, right? But that cardiac output is low. Why? Where is all the fluid that the heart's supposed to be pumping out? In the interstitial spaces, not in the vascular space. So that cardiac output is down. That cardiac output is down to the entire body, including the GI tract. That's why you're seeing this, guys. So what do you think is going to happen to that GI tract when it's not getting the oxygen, vitamin, nutrients, minerals that blood carries? Do you think that peristalsis, do you think that bowel sounds is going to be increased or decreased? Decreased. Those organs are going to start shutting down, just like the kidneys did. Let's take a look. Peristalsis decreases, and a paralytic ileus may develop. Nothing's getting through there. Secretions and gases collect in the GI tract because remember, nothing's moving. So secretions and gases collect, causing abdominal distension. Curling's ulcer, I put a star next to it because they, you test questions on it a lot when it comes to burns. You need to know it. Curling's ulcer, this is acute gastroduodenal ulcer that occurs with the stress of a severe injury. That can occur within 24 hours after a severe burn injury because, look at this, because of reduced GI blood flow and mucosal damage. The body's trying to survive. Something traumatic has happened. So yeah, that heart rate's increasing, but there's no cardiac output, which means the GI tract is not getting that blood that's full of minerals, oxygen, vitamin, nutrients, everything that it needs to function. So it stops functioning. And beside that, peristalsis decreasing, besides that gas accumulation that can happen, patient can have the Crohn's ulcers just from the stress on the body. This complication is now less common because of the use of H2 blockers, PPIs. These are drugs that protect the GI tissues and early enteral feedings. Any patient that has burns, they're not going to be fed peel. They're going to get enteral nutrition for a certain amount of time. Okay, so guys, this is just part 1 of burns. Part 2. We're going to start here, best practice for safety and quality care of the person with burns, emergency management of burns. So guys, please in the comment section, let me know what you thought about this video. Let me know what you'd like to see me do a lesson on besides burns. If you have any questions, something I haven't covered yet that you are, what's the word I'm looking for? Curious about, go ahead, let me know in the comments. Please, if you guys want to support this channel, I see your comments all the time. Thank you guys for the words of encouragement. But you want to support this channel, the best thing that you can do for me is share my content. Share it on your social media site. Share it with your nursing instructors. Share it with your friends who are thinking about the nursing program. That will help support my channel. Don't forget, I have audio lessons available for you on my website, nexusnursinginstitute.com. And of course, you guys can catch me on Facebook, Instagram, and TikTok. Guys, thank you so much for watching this video, and you guys will see me on the next video.